the next 20 minutes, we're going to start by thinking about where we are with clinical guidelines, but I actually will not focus all that much on guidelines per se. I think all of us have in medicine a love-hate relationship with clinical guidelines. We understand that they can do a lot of good, but maybe we don't like working with them, maybe we're suspicious of them. And people have thought long and hard about what these are for. You know, the benefits of having good clinical guidelines are that they actually can improve clinical decisions. They're based on good evidence. They can improve health outcomes by promoting things that actually are proven to be beneficial, discouraging ineffective practices. They make care more consistent, possibly. They may empower patients. For example, if a patient doesn't know that they should be getting such and such a therapy for a condition, they can actually go to their patient and say, their physician and say, why aren't you doing this? Might influence public policy, support quality improvement for sure, because when you standardize things, then you can start to measure outcomes in a rigorous way, show gaps in evidence. They are also a crutch for medical legal protection, so if you adhere to the guidelines, harder to be sued, and they should improve cost effectiveness. On the other side, there are potential limitations and harms. The recommendations may be wrong. They're only as good as the evidence and the people that went into it and making it. They can be influenced by opinions and experience of the group who developed them. There may be a lack of scientific evidence, and you see many guidelines that are based on low levels of evidence just because the evidence isn't there. Sometimes they're outdated. Scientific evidence can change very quickly. We get this phenomenon of conflicting guidelines. So, for example, if you look at the routine for surveillance colonoscopy and IBD, you'll see different guidelines from Britain and the United States, and even in the United States, slightly different between different organizations. So that leads to some confusion. The result of all this may be that you have ineffective, harmful, or wasteful interventions baked into guidelines. They can be inconvenient. They certainly take time if you truly adhere to them. Patients may have different priorities from what society's priorities are and payers' priorities and risk managers. And I think the thing that bothers all of us, who use these things the most is that they may be inflexible and they may harm by having insufficient room for clinical judgment. So I think that sums up the situation, but whether we like them or not, clinical guidelines are here, and they're going to be used more and more. But really what I'm going to talk to you for the rest of the time are not so much guidelines, but what we can do to work around guidelines, within guidelines, but also supplement them to improve the outcomes for our IBD patients. And I think there are three ways today in which we can consider personalizing therapy to potentially improve outcomes. And the three things are, first, risk stratification to tailor your first choice of therapy based on the risk profile of the patient. The second is using a treat to target strategy, and included in that is a strategy of incorporating biomarkers of inflammation to monitor disease. And the last way is by incorporating therapeutic drug monitoring. So let's embark on this journey of personalized therapy. And these are the most recent guidelines from the American Gastroenterological Association, rather long guidelines, but have nice flow charts. And it starts with an assessment of the patient. And at its heart, what is really different about these guidelines is that what it intends to do is divide patients into low-risk patients and high-risk patients. The low-risk patients probably comprise something like 35%, maybe 40% in population-based cohorts who don't have very highly progressive disease. They have indolent disease. They have long-term very good outcomes. The majority of patients, though, are really high-risk patients that fall on the right in blue and green. And then what you're supposed to do for these patients depends on whether they're high-risk or low-risk, and whether at the moment that you're seeing them, they're in remission or they have activity of their disease. I'm going to focus on some of the prognostication factors that were put into this guideline. And basically, they divide low-risk and high-risk patients according to a number of variables having to do with age of diagnosis. So the median age of diagnosis for Crohn's disease is roughly 30 years old. And if you're diagnosed below that median age, you're higher risk, and if you're older than that, you're lower risk. Anatomic involvement, if it's more limited, that's good, but if it's very extensive, then obviously that's a risky situation. Notice that this gives a lot of room for judgment about what extensive means actually. We do know that the presence of perianal or severe rectal disease is associated with really bad outcomes and proctectomy in some patients ultimately. Endoscopic variables like deep ulcers are thought to be a bad prognosticator. And of course, the patient who's already had a surgical resection is at risk for more surgical resections, and ultimately some patients, even now, do get short bowel. And then finally, the patient who already manifests complicated disease behaviors, either stricturing or penetrating disease, is at higher risk. And some patients will have these manifestations even at baseline, probably even 10 or 15% will have a stricture or a fistula at the time that they're diagnosed. So once you've sort of incorporated these judgments into dividing the patient as low risk, or you can say non-low risk, incorporating moderate to high risk, the options that were put in, and mind you, these were probably created in 2012, 2013, and published in 2014, so it's already out of date and missing some things. Again, one of the limitations of guidelines that are already pointed out to you. They give you a few options. One is anti-TNF monotherapy. That's better than no therapy, certainly, or thiopurine monotherapy. Anti-TNF plus thiopurine is better than thiopurine alone or monotherapy, and methotrexate for patients who don't tolerate purine analog in combination is another thing that they put in here. But of course, we have additional drugs in our hands now. We have ustekinumab, we have vedolizumab, and these things could also be considered. So why is it important to do the right thing for the high-risk patient up front? It's because early in the disease is when you have your best opportunity to really get the disease under control and set the patient on the right course. And I think this post-hoc analysis from the SONIC study, which keeps on producing more and more interesting findings, and I'll show you some more later, clearly shows you that if you divide patients into those who were treated in the protocol with early Crohn's disease, meaning they had less than a year and a half from their diagnosis, they had no prior immune suppressants or biologics, no fistulas, these patients actually did really well as compared to the non-early Crohn's disease patients. Look at mucosal healing and C-reactive protein normalization and clinical remission, that last thing on the bottom. You can get 2/3 of patients with combination therapy who have early disease to achieve that really stringent outcome. And if you look at the non-early Crohn's disease, that number drops by about 20% to 44%. So the first best hope is to treat the disease well and treat it early. So now that we have a few other agents that we could think about using relatively early, how do we consider positioning these things? And as always, it has to do with efficacy and safety. Obviously, we can't ignore the fact that insurers do have some element of control over what we may choose, but putting that aside for a moment, there are differentiating factors. I think safety is one differentiating factor when you're looking at the anti-TNFs versus vedolizumab and ustekinumab. We have the whole list of things that you see there on the column in the lower half on the left under anti-TNFs that you know very well. There's a lot of data missing with regard to early disease, combination therapy, and so on when we're talking about vedolizumab and ustekinumab, quite simply because we haven't had these drugs for 20 years like we have with the anti-TNFs. And then there are elements that the patient will help you consider, such as convenience of subcutaneous dosing as opposed to intravenous dosing. So all these things are factored in. So the positioning considerations that have to do with the patient have to do with the age of the patient and therefore the safety profile of medications, the severity of the flare, whether the patient is hospitalized or free living, what the patient has already been on and what they have been through and were refractory to. The presence of fistulizing Crohn's disease is fairly decisive because the best data that we have is for anti-TNFs. The presence of extraintestinal manifestations may steer you slightly away from vedolizumab, although there is some data to suggest that that may work for some extraintestinal manifestations. The setting of post-operative prophylaxis is different. We talked about the newly diagnosed patient, and other comorbidities, cancer, prior infections, and so on. So all these things play a role, and it makes it not really cookie cutter for every patient, but really an individual personalized judgment. I also bring to your attention this publication, which really is not in hard paper yet, but is published online, which was the development of a disease severity index. So disease severity is a concept different from disease activity. It has more to do with how bad is the course of the disease going to be rather than what are you seeing in terms of symptoms right now. And I'm not going to go through all of these factors, but you can see what was put into this index. I also have to admit that this was done by the BOPSAT method. Do you know what that is? That's a bunch of people sitting around a table. And so it hasn't been validated yet in the real world. This was the opinion of experts saying these are the things that we think are important, but done in a fairly rigorous way. So mucosal lesions are graded, presence of fistula or abscess or prior resection, a stoma, obviously very significant, disease extent, defined as you see here, and then some symptomatic things like the frequency of loose stools, stricture, another complication, a biomarker, CRP, and prior biologic and immune modulator use. And then furthermore, they incorporate impact on daily activities, albumin, anorectal symptoms, anemia, abdominal pain, and steroid use. And all these things are scored with different weights that had to do with how much the experts thought these were important. So I think we need to see validation of this, but it gives you a little more concept about what a severe patient looks like. So we're going to move now to the second approach to personalized therapy, which is treating to target. And I think you've heard a lot about this at this meeting, and it's a concept that really is gaining steam as a way, potentially, of keeping a patient in control. You might call it tight control, if you will, and keeping them well for long periods of time. The concept is that we set predefined goals of therapy, and we'll talk about what those might be, that there's regular assessment of disease activity which needs to incorporate objective evidence of inflammation, not just symptoms, not just asking a patient how they're doing. And then based on those objective findings, in large part, adjusting treatments down the road with predefined therapeutic consequences and targets for that, and intervening early in high-risk patients. So the question until relatively recently is, does this approach actually improve outcomes? And I think there are a few studies, one very important one called CALM, that was just published 3 days ago that suggests that this approach can improve outcomes. So this is not a new approach in medicine. If you think to what we do in diabetes, we're treating to a nice single target of hemoglobin A1C. In hypertension, we have therapeutic goals there. If we're talking about risk factors for cardiac disease and LDL cholesterol, we have goals there. The nice thing is that we have a single number for these things, and we don't necessarily have a single numerical target for something like IBD, which makes it a little more challenging. So another BOPSAT approach was the STRIDE effort, selecting targets of remission in inflammatory bowel disease. This was an IO-IBD initiative, and this consisted of 28 IBD specialists from around the world who developed, through a consensus opinion method, 12 recommendations for essentially what is a treat-to-target approach. And really to boil down a lot of work into one slide, the targets for ulcerative colitis were a patient-reported outcome, the goal of which is resolution of rectal bleeding and resolution of diarrhea or altered bowel habit, combined with an objective outcome of endoscopic remission. This means a Mayo endoscopic subscore of 0 or 1, meaning no ulceration. And histologic remission was thought of as an adjunctive outcome, although I think even since this was published a few years ago, there's steam gaining on the idea that histology is actually quite an important and maybe even better outcome than endoscopy and UC. For Crohn's disease, in parallel, also a patient-reported outcome, but here instead of rectal bleeding, you substitute abdominal pain, and you still have diarrhea resolution as a target. And you have objective outcomes of endoscopic remission, meaning resolution of ulceration at ileocolonoscopy, or on cross-sectional imaging by MRE or CT enterography, especially important for patients who you can't cover the whole disease by ileocolonoscopy. Now, in this statement, the consensus statement that Stride put together, biomarker remission was thought of as an adjunctive target to achieving these goals. And I reiterate that these are goals, these are ideal targets, and they may not be achievable with the drugs and methods that we have now, but it's what you should be striving for in the process of care. Why are we not just relying on symptoms? I think, particularly in Crohn's disease, we've come to understand that symptoms really don't match very well with the objective findings of inflammation. And if we go back to Sonic yet again, you can find that there are patients who have complete mucosal healing, and only 57% of them are in clinical remission. And so you'll be wrong a lot of the time, and there are patients who are not healed who are also in remission. So you'll just make errors in two different directions, and if you rely on this for important treatment decisions like intensification of treatment or changing a treatment, you'll be wrong very often. The other thing is that objective outcomes such as C-reactive protein, which granted is a biomarker, can give you a higher likelihood of progression of the disease. So this looks at progression over 5 years of the Le Mans score. The Le Mans score is a bowel damage index that has been validated. And if you have a high CRP, you are much likely to have deterioration of your Le Mans score over a 5-year period. So even if you don't have symptoms, this is what silent Crohn's disease means, a concept developed by David Binion at Pittsburgh. But if you have evidence of inflammation, even if it's subclinical, not symptomatic, you're going to have worsening outcomes. Conversely, the patients who can achieve mucosal healing have better long-term outcomes. We see this in Crohn's disease. The patients who have incomplete healing are much more likely to have progression to a surgery. And so that all is evidence for objectivity of your assessment. So if we think about this, this is an algorithmic approach that is iterative. It involves making a treatment decision based on objective findings, treating the disease, and then after that, at an appropriate interval, which may be different for different drugs potentially, it might be 3 months, it might be 6 months, but the point is you're going to look again. And since looking means something expensive and invasive like a colonoscopy or an MRE, you can't only rely on that. You also probably need to incorporate biomarkers into your regimen. And this probably in Crohn's disease means CRP for those 70 or 80% who mount a CRP, or fecal calprotectin for the others who don't. So just to give you just a tiny taste of the enormous amount of data out there on different biomarkers and IBD, what I would say is that if you're going to use fecal calprotectin, the best evidence is in Crohn's disease is really for colonic Crohn's disease, and we could say for ileal Crohn's disease after an ileal resection might also be useful, but that's a slightly different story. It is also useful for ulcerative colitis. Now, interestingly, in this very recent study, you can see that the sensitivity of fecal calprotectin was highest when you're looking at histologic outcomes, even better than in endoscopic outcomes, although the specificity was highest in detecting endoscopic outcomes. And as usual, we see not the best match with clinical outcomes, although still not terrible. So this can be used, you can incorporate it. And then, you know, the other question is, we're doing all this treat to target stuff, we're monitoring, we're making adjustments, does it do any good? So we have this retrospective study from University of San Diego, University of California, San Diego, where patients had dose adjustment to achieve mucosal healing, and it was compared over time to those who didn't have dose adjustment to achieve mucosal healing, and much higher rates of mucosal healing and histologic healing were accomplished. So now turning to the third and last approach is therapeutic drug monitoring, and there are a lot of questions about this still. It's very much in evolution. There are questions like, what is the relationship of drug exposure to the response? Can we define a minimum effective concentration for all of our drugs? And the answer is, I think we can. Can we define a maximum therapeutic concentration above which there isn't any additional benefit? Maybe there would be more toxicity, although probably not for biologics. And the real questions that we have are when to use therapeutic drug monitoring. Should we be doing it during induction even, or in maintenance, or as we more typically do now, in loss of response? Now, loss of response is what most of us, the situation most of us would do therapeutic drug monitoring. And this algorithm states it as well as anything, which basically says if a patient loses response on their biologic, you should measure for drug levels and antibodies to the drug, and if there are therapeutic levels to the anti-TNF, then probably the patient is not responsive to TNF blockade anymore, and you should move on to a different mechanism drug. If there are low levels, but there are no anti-drug antibodies, then the PK is not optimal, and you need to either increase the dose or the frequency. And if there are anti-drug antibodies, then you've lost response. You can switch within class and still see the patient do well. There's also a role for establishing the causation of primary non-response to a drug. Patients can fail very quickly with a biologic, and you won't know why unless you check a drug level. And it's interesting that a large number of patients will have low troughs very early in the course of therapy, and immunogenicity can also be an early phenomenon, even less than 6 weeks. And you would never know this unless you really checked and looked. Early assessment of drug levels is coming into more vogue, and we know that if you check drug levels as early as week 14 for Infliximab, this is associated with longer-term outcomes at 1 year, same for adalimumab, and findings also consistent in ulcerative colitis. I think one study in this area that's quite interesting, even though it was a negative study for its primary outcome, was the TAXIT study, where they had patients on stable doses of Infliximab who were in clinical response, and then the dose concentration, the trough concentration was measured during the optimization phase. And then the randomized part was actually less interesting. They dose adjusted, and that actually didn't produce any benefits. But I think that's because they optimized at one point in the study. And the baseline characteristics are very telling. You have a quarter of patients who have therapeutic concentration that may be too high. You have about 44% in range, and you have about 30% who are either undetectable or below the limit of what should be therapeutic. So a lot of people are too high, a lot of people are too low, and unless you check and adjust, you don't know it. So what happens when you optimize in Crohn's disease is you see response rates go from, or remission rates go from 65%, all of them were in response but not remission, up to 88%. Interestingly, it had no effect in ulcerative colitis. And likewise, you saw the C-reactive protein appropriately go down, telling you that it wasn't just symptoms but actually biologic. So this approach has also been incorporated into clinical practice. This is Adam Chaffetz at Beth Israel Deaconess in Boston, where basically he had a habit of measuring trough levels at each and every infusion, and if the level was low, he would tinker it upward. If it was high, he would tinker the dose downward. And sure enough, the patients who got optimization in that way did much better on that regimen than the ones who were not optimized. And as we might expect, the ones who maintained a trough above 5 did much better than the ones who didn't. And then we have further data from this same cohort showing that those same dose-optimized patients also had fewer surgeries and hospitalizations. So this suggests that this approach could save money. And then we also have this little interesting piece of information which suggests, again from the SONIC study, another role for therapeutic drug monitoring, which is measuring drug levels before you stop combination therapy, because it turns out that most of the effect of azathioprine in combination therapy is to boost the level of the infliximab. And level for level, you get the same level of efficacy as long as the level of infliximab is maintained at the same place, with or without the azathioprine. You should know that higher infliximab trough levels are not associated with increased adverse events. If you look in the bottom lower right of the graph, actually fewer patients had infections with higher levels of infliximab, suggesting that the efficacy actually reduced the numbers of infections. And also, you should know, conversely, that if you drop the levels for patients who have high levels, if you drop the doses, you will actually end up saving money. And this in itself, if you dose de-escalate to achieve reduction in supertherapeutic doses, is cost-effective and compensates in some systems for the cost of monitoring for the drug. We're only just understanding the dose-response relationship or exposure-response relationship for vedolizumab and for ustekinumab. For vedolizumab, there is a exposure-response relationship that is not quite as linear as we see with the anti-TNFs, but it is there, and the suggestion is the level should be higher than 20, I believe, is what is said. And for ustekinumab, we're starting to understand that patients who achieve levels higher than 4.5 are going to do much better in terms of endoscopic response and endoscopic remission and overall. So that seems to be the cutoff for that one. And finally, different indications may require different levels. So the patients with perianal fistulas, on average, do better with higher levels of infliximab at least, and levels, trough levels greater than 10 were an independent factor in this study for predicting fistula healing. I think that has to be looked at prospectively, but it suggests that you need more to do this. So in summary, we have concentration levels that we know. You see them listed here. Loss of response, I think we all understand, but I think there is a growing interest in incorporating therapeutic drug monitoring even early in the course of the disease to personalize. So just to conclude, guidelines are important, but they're an important point of departure for very personalized care for the individual patient. And risk stratification, treating to target, and therapeutic drug monitoring are all ways that you can do right now to actually achieve the best results. So thanks very much.